Hello, I'm Donal McCauley and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Toronto and I'm talking to Eva Grunfeld. Eva, let me take you back to your childhood really, because that's really an interesting start. What brought your interest in medicine?
Yes, well, I have to forewarn you that it was a very negative attitude to medicine. And so it certainly wasn't that I dreamed of being a doctor when I grew up. I grew up in Montreal, family of new immigrants from Czechoslovakia, didn't speak English. My parents didn't speak English. So it was really when the kids started to go to school that English was brought into the household. I was in a pretty severe car accident when I was 11. I was hit by a pizza delivery truck, sustained some serious injuries. It involved 6 months in hospital, 2 months in a body cast, so 6 months of not moving essentially, and then complications that followed from that, from both the medical treatment, primarily complications related to the iatrogenic complications. And so really 10 years of my life, from the time I was 11 till I was 21, was sort of in and out of hospital and surgeries and things like that. But my family really experienced everything one hears about in terms of an immigrant family in a system that they don't understand, that was complex. That this was before there was Medicare available in Canada. So there was, the financial toll of it, but primarily it was a completely disjointed experience. It was, we would see one specialist and there was no communication. There was no family doctor. So it was a very, very, very difficult period. And obviously I was an adolescent, so I was going through that. But it left me with very strong feelings of antipathy, to use a gentle word. I might have used different words at that time, towards the healthcare system.
Well, you certainly did a U-turn and off to medical school. I think you went to McMaster. And then what did you do then after that? What were your career aspirations after McMaster?
So my original academic background, my first degree was in comparative literature. So, and it was only after that I studied the sciences. So I have both a BA and a BSc, and then did an MSc so I was studying nutrition. I did a master's in nutritional biochemistry and was working as a nutritionist. And then that's where my interest in medicine really started. And I went to McMaster. I had already come from a research background in that sense, through my master's. And so I did have a research orientation. I had, one of those incredibly fortunate things in life where David Sackett, Gord Guyot, but David Sackett was there, and I did several electives with him in CanIMPACT. I pretty well knew when I started medicine that I was interested in the clinical career, but I was interested in being a clinician scientist. So how to achieve that was, the complicated route. I did my residency in family medicine in Ottawa. And then after working for a few years clinically, I went back and did a DPhil in Oxford in really essentially cancer epidemiology. And my advisor was, the professor of public health, Martin Vesey. And so I spent 3 years in Oxford, did my DPhil, and then came back to Canada, where if I said there was one unbelievably lucky thing that happened to me, it was that I was awarded a clinician scientist award through a provincial program. And that was really what started my progress as a clinician scientist.
Tell me then, what brought you to Oxford?
I had a very specific idea of what I wanted to do. I had really a specific idea. So I wanted to go somewhere where I could do that piece of research. I did explore going to U of T, to McGill. I think those were the two local institutions that I explored. And then I happened to be, my husband and I were on a canal trip in the south of France, and then we were in England, and I had sent a letter to Martin saying, can I meet with you? I was expecting really just to have a conversation. And at the end of it, he said, well, if you want to come, I'll be your supervisor. So it was a bit of happenstance, but I was looking for a program, which the DPhil program, as you know, is a research-based degree. It's not a course-based degree. And so that allowed me, I'd already done a lot of the kind of, science courses and stats courses and things like that. So I really wanted somewhere where I could do the piece of research that I was interested in.
Now, before we get on to your career as an epidemiologist, you have another qualification which intrigues me, and that is a qualification in acupuncture.
How did you find that out? I'm impressed. There are not many people who know that. Yes, I am a Chinese trained acupuncturist. So how did that come about? I think, like all good questions or motivations, it stemmed from clinical experience. So this was, I was doing my residency in Ottawa in family medicine. And at that time, my mother-in-law developed a facial herpes. And she had, an imbalance. And she was very, very distraught about it. This was a woman who was conventional and conservative in every way you can imagine. I mean, she was a lovely person and I adored her, but she was not the kind of person you would expect to explore alternative medicines. And yet she was so desperate for a solution that she started to see an acupuncturist. And I was really struck by, first of all, how much hope and faith she had put into that treatment. And so obviously, having been nurtured at Mac and CanIMPACT, I was asking myself about the evidence and how much she spent on it. I really felt I wanted to learn more and to understand more. And there was a fellowship program for Canadian or Ontario physicians to go and study at the Nanjing College of Traditional Chinese Medicine and study acupuncture. So that's what I did. And I trained and passed my exam in Chinese.
It's really intriguing that you combine your scientific basis of clinical epidemiology and alternative medicine.
Well, I don't know how much you know about the debate about alternative medicines, but there's a strong principle within alternative medicines, or there was at that time, that they were not amenable to scientific investigation. That was too reductionistic was the terminology that people talked about, that the treatments were multifaceted and individualized, and therefore, a clinical trial was really not feasible. I felt, and given my CanIMPACT training, and I published about this and have given some lectures about this. I felt that if you're studying an outcome, I mean, there are many areas of medicine where we studied outcome before we understood the pathway, before we understood the underlying mechanism. And even if we think about, the early vitamin studies, the relationship between niacin and pellagra, the relationship between scurvy and vitamin C. I mean, those were all approaches that looked at the outcome way before there was even an idea of what a vitamin really was. So I think that can be translated to alternative medicine, because most people in my experience, and certainly even in my experience in China, went there with a specific complaint. So the Nanjing College of Traditional Chinese Medicine is one of the most ancient, and it prides itself on combining Western, its associated hospital prides itself on associating Western medicine, offering both Western medicine and traditional Chinese medicine. So many of the patients came to the acupuncture clinic with a Western diagnosis: high blood pressure. Bell's palsy was very common. I don't know the epidemiology of that. But anyway, so to my mind, particularly in a Western context, people have a specific complaint: smoking cessation, attempted smoking cessation, that can be measured objectively. And even if the treatment is individualized, I don't think that that precludes being able to study it. It might preclude being able to deconstruct or dissect which aspect of the treatment worked. But it doesn't preclude studying whether or not this package of alternative Chinese medicine, with the examination of the flow of qi and the balances, and whatever acupuncture points are prescribed, whatever that treatment is, and even if it's variable from person to person, you can still study in a rigorous, controlled way the outcome and whether the outcome is measured. So that's kind of the combination. I think that's how the combination of the two. And I did do a trial of P6, which was commonly used. You hear about these bands that people use for seasickness. So that's the P6 point. And a lot of people use it in the clinic for mild chemotherapy-related nausea and vomiting. So I got the company to make bands without the pressure point. And we did a randomized trial to see whether or not it improved mild chemotherapy-related nausea and vomiting. It was a negative trial.
So let's bring you back to your career as a clinician, epidemiologist, and you're interested in cancer.
So my first year after residency, which was in family medicine, I was looking for that perfect 9-to-5 job. That was, I could recover from all the years. Anyway, I worked as a physician in the Ottawa Regional Cancer Center, primarily in breast cancer clinics. And one of the things that struck me, so this was in the late 80s. And one of the things that struck me was, on any given day, the clinics were overflowing. And the breast cancer, so specifically I was involved in the breast cancer clinic. The breast cancer clinics were overflowing. The vast majority of people were there for follow-up, for routine follow-up. The clinical skills that I needed in order to provide that care, I had the minute I walked in the door. By that, I mean that my training as a family physician afforded me all the clinical skills and knowledge specifically about breast cancer follow-up, the routine follow-up of breast cancer patients, that I needed to provide the care. The other thing that really struck me and disturbed me was that the demand was so huge, the clinics were so full, the time was so short, the amount of time per patient was so limited, that when indeed there was a patient who had a problem, a concern about recurrence, or perhaps was in need of, was palliative and needed symptom control, there was no time to deal with them. And often at that point, if there was a question of palliative care, we would be searching for the family doctor, because the patient had been so focused on breast cancer follow-up and coming to the breast cancer clinic, they often had lost contact with their family doctor. So I had two things in my head. One, hey, I'm a family doctor and I kind of know how to do this. And the other is, why has this patient had no contact with their family doctor in all these years when there are other medical conditions that they need to be thinking about? So those were the experiences that I had that made me question whether or not really routine follow-up can be provided by the family doctor as safely and effectively. I'm giving you my hypotheses. And that was a pretty radical idea.
And this brought this idea of survivorship plans.
Yes, yes. People were not talking about survivorship at all. We, at that time, the terminology used was routine follow-up. But then, with the Institute of Medicine report, things began to broaden, realizing that 80 to 90% of people, if we talk about breast cancer, the same applies to other cancers, prostate cancer, colorectal cancer, the major adult cancers, that the majority of people will be long-term survivors. For those people, there is a need to look at other preventive measures related to other medical conditions, as well as to be aware of other cancers that they might be at risk of. So the survivorship concept was really moving from a unilateral focus on survival for the index cancer to a much broader, holistic focus on the needs, the preventive care, the chronic care needs of the patient, and specifically what they are. And that often also includes psychosocial support and, which issues related to quality of life. So that's where the survivorship concept came to. I was really, definitely to my knowledge of the literature, only the second person to ever do a trial. There had been one trial out of Italy before that. I did several major trials. So I was really in the vanguard, I would say, of going from thinking about it as index cancer follow-up to survivorship care.
Now, you mentioned other conditions in addition to cancer, and that brings me on to ask you about your other interest, which is in communicating preventive strategies.
Well, it doesn't take long, both from a family physician perspective and from a knowledge of the epidemiology, to realize that we are really in a crisis of chronic disease. The World Health Organization some years ago, moved from primarily being focused on communicable diseases to recognizing that non-communicable diseases, which is, WHO speak for chronic diseases, are actually one of the most significant international concerns internationally in all countries. And so I really felt, again, with the family doctor perspective, that one of the errors that we make in talking about prevention and thinking about prevention is we are so narrowly focused. We will have programs for breast cancer screening. We will have programs for colorectal cancer screening. Your family doctor will talk to you about, diabetes and preventing, but we do it in a very siloed way without actually, I think we understand it. I think everybody understands it, but nobody can think in that broad term. We need to be thinking about prevention, screening and prevention for all chronic conditions at the same time. Because first of all, upstream factors are common to all of them. These are the lifestyle factors. We all know this. How can we integrate the prevention? When I say prevention, I'm really meaning screening and prevention for all chronic conditions in a unified message for patients so they can understand the relationship between these conditions and understand how an intervention on one of the upstream factors like exercise, weight control, will have an impact on all of the conditions rather than thinking of it in a very kind of, narrow way. So that was kind of I think the insight that led me to the work I've been doing under the rubric of what we call better.
Now I'm going to bring you full circle and finish up with something you're involved in at the minute, because you spoke as a young immigrant family in Canada and the language difficulties, but now you're helping a new wave of immigrant families deal with language difficulties.
Yes, so this is my current project, and I'm very excited about it. Yes, I mean, I have obviously great inherent empathy for the plight of people who are new immigrants to the country, to Canada, having lived it. And just by happenstance, it's one of my policies in life is just say yes. If somebody's giving you an opportunity, just say yes. So I'm sure you know Reg Perkins, very famous person in family medicine in Toronto, certainly. And he and I we met at the conference, and we were just kind of chatting. And he said about what we were respectively doing. And he told me about the Syrian refugee family that his church had sponsored to come to Canada. And that the mother was an obstetrician gynecologist from Syria. She had realized she would never really be able to practice medicine in Canada, and had identified the possibility of becoming a midwife. There were 4 children. The refugee supplement that they had been offered by the Canadian government was coming to an end. It was really quite important to earn a living as quickly as possible. But what Reg said was that the biggest problem she faced with no English when she came, she'd been taking English as a second language. So the biggest problem she faced was that she had nowhere to learn the lingo, the medical, the terminology, the acronyms, the abbreviations, and the opportunity to practice speaking those things in a high stress situation. So I offered to help her. And we met once a week at a coffee shop, and we brought our obstetrical instruments with us, which had the other visitors to the coffee shop rather shocked. Anyway, so she did get into the program. She graduated. She's now a midwife. Her kids are doing great. It was very rewarding. So we're just launching this program. We call it HELP, which stands for Health English Language Pro, and it will partner volunteer physicians with internationally trained health professionals with some materials that we've developed. The goal is really just to improve the fluency in using what I call the secret language of medicine, medical terminology. And I mean, there was an article in the national newspaper about it, the Globe and Mail. And I've already been contacted by about 20 different physicians saying, okay, I want to volunteer.
That's another fabulous success story. And Eva, thank you very much for sharing so much of your life, your contribution to Canadian medicine. It's no surprise that you were given the Lifetime Achievement Award, and it's absolutely no surprise that you're of the Order of Canada. Eva, it's been an absolute pleasure talking to you. Thank you very much indeed.